Well, good morning, everyone, and welcome to our Grand Rounds, Cardiology Grand Rounds at Houston Methodist. It's a pleasure having you. And today also we have a wonderful treat to share science and friendship with us, Dr. Thomas Wang. Um, he's the director of the Division of Cardiovascular Medicine at Vanderbilt University Medical Center, and I had the pleasure actually visiting with him about a year and a half ago. And this is where we started a friendship and a collaboration. And he is the physician-in-chief for the Vanderbilt Heart and Vascular Center, and he's the inaugural holder of a chair, Gottlieb Freisinger Chair in Cardiovascular Medicine. He's a graduate of Harvard and actually stayed in the region in Boston. Actually, he is from the Boston area and was at Harvard as well as the Mass General Hospital for many years of his early career, where he did also a postdoctoral research fellowship at the Framingham Heart Study, and this is where his interest in biomarkers and other determinants of cardiovascular health really started, and I think he has been a leader in this area, also tapped on to serve on several committees that deal with genomics, with markers, biomarkers in determining health and disease. The research focused on the role of natriuretic peptide in cardiovascular health, identification of novel markers and mechanisms, obesity-related as well as heart failure-related. He's extremely well published, and actually he's been quoted to be among, by Thomas Reuters, to be among the top 1% of individuals who are cited in the field. He's trained numerous fellows. Vanderbilt actually has a almost sustained a T32 grant for training. And he is president of the Association of Professors of Cardiology, and this is also where we collaborate as chairs of cardiology nationally. He is also a member of several associations of the American Physicians, Association of University Cardiologists, and also he's been tapped to chair the American Heart Association Committee on Genomics and Precision Medicine. And I think this is one of his topics today, talking about precision medicine, and I think this will be very informative for us, so please, let's help welcome Dr. Wang to Houston. Great to have you.
Thanks very much. Really appreciate the kind introduction and the opportunity to visit, connect with some old friends and new friends. It's really a thrill being here. So as Bill mentioned, one of my hats that I wear at the AHA is to chair this scientific council on genomics and precision medicine. And it's actually a council that used to be called Functional Genomics and Translational Biology. We actually rebranded about a year and a half ago. One of the reasons, of course, is because we are surrounded by precision medicine. This, in some ways, is the era of precision medicine. Some of you may remember that one of the last things that President Obama did in the last year in office was to announce a precision medicine initiative, almost $1 billion of NIH government funding devoted to developing a large cohort of individuals who are going to get genotyped and phenotyped in the United States, now called the All of Us Initiative. And of course, it's been in the lay press. This is a cover from Time magazine a couple years ago. And of course, the marketing around precision medicine. So this I thought was clever. This is from Sloan Kettering. There won't be one cure for cancer, there will be millions. And so we are surrounded by these concepts. I think when you think about what precision medicine is, for me, one of the best definitions is based on what it's not. And what it's not is one size fits all. And so the idea, of course, or the implication is that a lot of the medicine that we practice is based on taking large groups of people and finding uniform therapies for them, whereas the concept of precision medicine is to take individuals and based on their individual characteristics, choose the right therapy for them. And so the purpose of the talk today is to think about cardiovascular disease in the context of precision medicine, and particularly focus on something that I've been interested in studying since I was a trainee, which is the prevention of cardiovascular disease. So I'm going to start with some vignettes just to give an idea of what the unmet clinical need, I think, is. The year 2000 was actually when I was in the first year of my cardiology fellowship. So if those of you will think back to the year 2000, consider that you have 3 patients that you're seeing. One on the left is a 32-year-old gentleman who's very physically active, has no family history of heart disease, no cardiovascular risk factors. The one in the middle is middle-aged, overweight, hypertensive, but has his blood pressure controlled on medications. And the one on the right is almost 60. He smokes, has had 3 MIs, a CABG, and even after his bypass surgery, he had 2 subsequent MIs. And so if I were to ask you a simple question in the year of 2000, which of these 3 people was going to die first? And in fact, if you could rank the 3 people in terms of the order or sequence in which they were going to die, I assume that most, if not all of you, would say the one on the right, the 59-year-old, the older one who had already had a bunch of MIs and CABG, was going to die first. The one on the left was hopefully going to live a long life. And of course, these are real people. So in the year 2000, Darryl Kyle, the man on the left, was about to win 20 games for the St. Louis Cardinals. Tim Russert was the host of Meet the Press, the one in the middle, and Dick Cheney was just getting elected Vice President of the United States. So Darryl Kyle died in 2002, 2 years after that initial encounter. Tim Russert died in 2008 of an MI. He'd actually had a stress test a month before and was given a clean bill of health by his physician. Of course, Dick Cheney is still alive and active. Now, he doesn't have his original heart. He was transplanted in 2012, but even if you censor that, he still lived another 12 years, many years beyond those of the other 2 gentlemen on the slide. And so the point here is that back in the year 2000, and in fact, still in the year 2019, there's no tool that we have in our arsenal as physicians that would have allowed you to identify the answer to the simple question of which of these 3 gentlemen was going to live the longest and why. The risk factors that's shown on the slide, any of the newer tests that we have to assess prognosis. And so we can't even tell people how long they're going to live or whether they're going to live a short time or a long time. Imagine the challenge of identifying precision therapies for these individuals. So as Bill mentioned, I did my training in research at the Framingham Heart Study. Framingham is the study that originated this concept of cardiovascular risk factors. It was actually coined by this gentleman shown here, which is Bill Cannell, one of the earliest medical directors at the Framingham Heart Study. So Dr. Cannell, who was actually still researching when I was a fellow there, and unfortunately passed away a couple of years ago, published his paper in 1961 where he identified the first factors of risk for development of coronary heart disease. Now, some of these had been in the literature before, but it wasn't until Framingham and the work of Cannell and colleagues that they started aggregating these factors. And these original ones that they published in the paper are shown in the slide below. And then subsequently, family history and obesity were added to that list. But as you can see, most of what we know about conventional cardiovascular risk factors has been around for over 5 decades. These are not new concepts. The challenge, as many people who think about cardiovascular prevention have been aware of for quite some time now, is that if you actually look at people who get heart disease, this is from a study over a decade ago, looking at a bunch of randomized trials of people with coronary heart disease, most of them have relatively few cardiovascular risk factors. And so for this study, over 60% of the individuals with established coronary heart disease had either no risk factors or only 1 cardiovascular risk factor. In fact, if you use most of the conventional risk factor scoring algorithms, most of the people who get heart disease would be graded as being at low to intermediate risk of having heart disease, which is known as the prevention paradox. And it's really a denominator issue, which is that although the more risk factors you have, the higher your chances of getting heart disease, risk factors, having no risk factors or relatively few risk factors is much more common in the population. So even though their rates are lower, the absolute number of events they contribute tends to be higher. And so it was around the time that I was a fellow at Framingham that there began to be interest in using different tools, including soluble biomarkers to augment risk prediction. And so one of the people that really advanced this concept was Paul Ritker at the Brigham and Women's Hospital, who started publishing on CRP, a simple marker of systemic inflammation, and showing in a variety of studies that healthy people with higher CRP levels had a higher risk of developing subsequent coronary heart disease. When I was a fellow, and as you can see, the lay press really took a hold of this, the idea of the heart test that could save your life. This was really something that people are very excited about beyond measuring cholesterol. Maybe they could measure this simple blood biomarker and really advance their understanding of who is going to get heart disease. So I was a fellow at the time, and we were interested in Framingham at biomarkers. And one of the things about CRP, of course, is it's not made by the heart. It's made by the liver. And so one idea was maybe if you actually looked at proteins that were synthesized in the heart, maybe those would be better predictors of who would get heart disease. And so we published one of our early studies on looking at circulating BNP levels in healthy people and future risk of cardiovascular disease. A couple of years later, working with this gentleman who was my original mentor at Framingham, Boston Ramachandran, we looked at the question of adding a bunch of biomarkers. And so instead of just one biomarker like a CRP or BNP, what if you look at a whole panel of biomarkers? Can you really predict who develops heart disease? And so these are the ones that we looked at in Framingham. They're here in the right column there. We looked at CRP. We looked at a bunch of hemostatic inflammatory biomarkers, some neurohormonal biomarkers. And what we found was actually a little bit surprising, which is that even if you measure these 10 biomarkers, although these biomarkers are individually associated with cardiovascular risk, even when you put them together, they actually don't advance your ability to predict who gets heart disease using a range of metrics. And so what I show here, and what I'm going to use throughout the talk, is probably the most broadly accepted metric, but it's only one of them, which is the area under the curve. And so as you may recall from your statistics, an area under the curve of 0.5 is a test that gives you no information. An area under the curve of 1.0 is perfect. And so anything in between spans the spectrum. 0.7 or so is considered reasonably good. And what you find in Framingham is that risk factors alone give you an area under the curve of about 0.75, 0.76. If you add these 10 biomarkers, it only budges that area under the curve a little bit to 0.77, which was a surprising result at the time, but has been recapitulated now numerous times in multiple epidemiologic cohorts. So without going into sort of statistical discourse, there are a number of reasons why biomarkers and other screening tests in cardiology don't work better. One of the basic reasons is that if you think about what we want with a biomarker, what we want is if there are two populations of people, healthy people who aren't going to get disease and unhealthy people who are eventually going to get disease, we want a biomarker that distinguishes between these two groups. The distribution of the biomarker in these two groups is completely separated. Unfortunately, biology doesn't work like that. And so with whatever disease you're talking about in cardiovascular disease, all the biological measures that we have broadly overlap. Now, the means of the groups may differ, and that's where we get our statistical significance. But the fact that they have such overlapping distributions means that at any given level, we actually don't know with any degree of certainty which group they're going to fall into. And so that led to the next question, which is, well, maybe 10 biomarkers isn't enough. What if you add 10, 20, 30, 40 more biomarkers on top of those 10? Now, when we did this simulation, we didn't have more than 10 biomarkers, but you can actually do a computer simulation. You take a data set like Framingham and plug in a bunch of imaginary biomarkers that have the same test characteristics as CRP. And so working with Mike Pensina, who is now at Duke, leading their biostatistics effort, we did a simulation based on Framingham data. What happens if you add anywhere from 0 to 100 imaginary biomarkers that all have the performance characteristics of HSCRP? What happens to your area under the curve? And so the area under the curve, or the C statistic, is shown on the vertical axis. 0.75 is where you start, because that's where you get just with conventional risk factors. And the point is to get this as high as possible. And what you find is that the trajectory, how quickly that area under the curve goes up, is largely dependent on this parameter here, the correlation coefficient. And that describes the correlation between pairs, the average correlation between any pair of biomarkers. So correlation coefficient of 0.4 describes the fact that the biomarkers that you're adding are moderately correlated with the biomarkers that you already have. In that scenario, you can add a lot of biomarkers, but you're not going to get your area under the curve to move very quickly. On the other end, if your biomarkers that you're adding have a low correlation, a correlation of less than 0.1 with the other biomarkers in the model, then you can get your area under the curve to increase relatively quickly. And so in some ways, this is just a formalization of common sense. When you add more stuff to the model, to the predictive model, you want the stuff that you're adding to not be correlated to the stuff that you already have in the model. Otherwise, it's not adding new information. And so although this seems basic, it actually exposes one of the common challenges in biomarker discovery. The traditional way to discover biomarkers is what happened after CRP was described by Dr. Ricker and colleagues. So inflammation, systemic inflammation, is an important pathway in atherogenesis. And so logic would have it, you should just measure a bunch of inflammatory biomarkers. So IL-6, IL-2, TNF-alpha. And so for years, the field did that. CRP was described, and then all of us started measuring a lot of other inflammatory markers. The problem with that is it's not going to add to your model because all those inflammatory markers are from the same pathway, so they're correlated with each other. The only way you're going to improve your ability to predict risk is to add biomarkers from other pathways so they're not correlated with the ones that you already have. And that is the fundamental challenge. So just stated differently, if you look at all the biomarkers that we'd studied in Framingham, most of them have at least moderate correlation to each other. There's little clinical value in measuring biomarkers that capture the same information. And so that led us to a bunch of work that continues to occupy us to this time, which is using omics or what we consider unbiased technologies. And so the idea with omics, of course, like proteomics and metabolomics, is that you're using a technology that allows you to profile hundreds or thousands, or in some cases millions of molecules in a sample without specific focus on a particular pathway. You're basically just looking at the chemical composition of that sample. And the idea is that by being unbiased, it gives us greater ability, greater chance of happening upon those biomarkers that predict disease, even though beforehand we wouldn't necessarily have guessed that that biomarker was important for disease. So this is Rob Gersten, my longtime colleague and collaborator, who's now at the Beth Israel Deaconess. We were both at Mass General when we started this work. And we started focusing on metabolites, metabolomics. Metabolites are sub-protein, sub-peptide molecules. We partly did that because metabolomic platforms because you're dealing with a much smaller number of molecules, tend to be a little bit more tractable for analyzing human specimens. So this is the mass spec platform that Dr. Gersten has in his labs based on triple quadrupole mass spec, which I won't go into. And we started with diabetes because we figured metabolites, look at metabolic disease, we'll see if we can predict diabetes. And so these are using Framingham data and the validation of the Scandinavian cohort. We described a bunch of small molecules, in this case branched-chain amino acids, that in healthy people without diabetes predicted the subsequent development of diabetes over a decade into the future. So you can take a healthy person, measure these things, and it would give you some idea of whether they're going to develop diabetes or not. And in fact, these, unlike some of the things that I described earlier, don't do a bad job of increasing your area under the curve. And so this is in collaboration with Jose Flores's group at Mass General. We looked at the C statistic for a bunch of things. We looked at genetic variants, the metabolite score, which actually did pretty well. And then if you add the genetic variants and the metabolites to just clinical risk factors like body mass index, you can move, at least moderately, the area under the curve for predicting diabetes. It's not a dramatic change, but it's still better than we were getting with cardiovascular disease. So metabolic disease and cardiovascular disease are related, so we also looked at cardiovascular disease. And the metabolites that we described do predict cardiovascular disease, but not tremendously. There's about a twofold relative risk of developing cardiovascular disease among the people who have high levels of these branched-chain amino acids. And again, area under the curve increments are relatively modest, again, in the range that you would expect with an inflammatory marker like CRP. And so we have, over a decade been doing this work, and one of the concepts in the field has been when you do this work, you measure a lot of things, is to make it publicly available. So we've made all our data that we've developed in Framingham and other cohorts available publicly online. And so all the data that come from these publications are accessible to any investigator who wishes to look at things, and they can relate them to all sorts of phenotypes. These are liver scans that were done in Framingham, but other phenotypes as well. However, our work, over a decade of work with metabolomics has led me at least to the conclusion that metabolites are relatively good for predicting metabolic disease. They're actually not that great for predicting cardiovascular disease, whether it's ischemic disease or non-ischemic disease like heart failure. And so we moved up the chain and decided to look at proteins. Now, proteins are much harder to do in an unbiased way. One reason is because where there may be a couple thousand metabolites in their bloodstream, there are tens of millions of proteins. And so it's very difficult with a single technology to capture that molecular diversity. In fact, this is another way of looking at the problem. This is hard to read, but the point is fairly straightforward. This is basically a bunch of proteins arrayed by their concentration range. And so the things on the left, like albumin, have a high concentration in the bloodstream. The things all the way here on the right have a very low concentration. And there's about a 10-fold order of magnitude, so 10 to the 10th range of concentrations. In other words, the difference between cytokines and albumin is 10 to the 10th range of concentration. To make that challenge even more difficult, if you think about the stuff that we actually measure clinically, they're mostly the stuff on this side of the graph, the things that have high concentration in the blood, like albumin, like the immunoglobulins. So the stuff that we might really care about, the new stuff, is way, way down here at low ends of the concentration range. And so for traditional platforms like mass spec that are sensitive, but not so sensitive that it's easy to distinguish proteins at this end of the concentration range, that's very difficult to do in human studies. And so we and others have tried a number of non-mass spec-based approaches. And so these are two of the ones that we have worked with. One is a platform from a company called SomaLogic that uses these things called DNA aptamers, which are basically like antibodies, but they're composed of DNA. And the advantage of them being composed of DNA is that you can then use standard genotyping technologies to produce a readout. And so the platform originally measured about 1,000 proteins, now can measure about 5,000 proteins in a single blood specimen. Olink is another company that has a similar approach. It does use actual antibodies, but they're ligated to DNA tails, so that, again, you can use in situ hybridization as a readout. The Olink platform measures about 1,100 proteins currently. And so there have been a number of studies now in the literature. We actually were not the first to use this platform for cardiovascular disease. This is from Peter Gans and his colleagues at UCSF, who developed a protein-based risk score using the heart and soul cohort as a secondary prevention cohort using the SomaLogic platform. Our study was published a little later in the same year using the Framingham cohort. And this is Debbie No, who's a postdoc, now junior faculty member in Rob Gerson's lab. These are Peter Gans's data. They proposed that these 9 proteins from the SomaLogic platform allowed them to predict in the secondary prevention cohort who was going to develop recurrent heart disease, increase the area under the curve from the mid-6s to about 0.7. We did a similar exercise in Framingham, came up with 6 proteins. Interestingly, these 6 did not overlap at all with their 9. The predictive value was a little bit more modest. It didn't increase the area under the curve all that much. But they were significant predictors of who developed coronary heart disease. And so these platforms are still early in evolution, but a number of groups, including ours, continue to pursue this idea that using these relatively unbiased proteomic platforms might allow us to identify more biomarkers of heart disease. But again, as you can see, we're really only still in the tens. There are probably, if you scan the decade of literature, probably only 10 or 20, maybe 30 good biomarkers of heart disease, good being at least as good as HSCRP. So we're not really at the point where we're increasing the area under the curve, the predictive value, the degree that we need to for clinical confidence. So one of the challenges with all of these studies is they're expensive, they're hard to do, and they require human blood specimens. And so you need very large study cohorts because power is an issue, especially when you're measuring hundreds and thousands of proteins. You have to figure out how to collect and store these biospecimens. Some of the endpoints that we're looking at, like coronary heart disease events, take a long time to accrue. So unless you're dealing with frozen specimens, you're sitting around a long time waiting for these events to occur. And then you have to validate the findings in some separate cohorts. So you basically double or triple the amount of effort that's required for these studies. So one of the things that my group has started to do after I moved to Vanderbilt was to try to think of other creative ways to attack the same problem, but not using the standard epidemiologic approaches of going to your freezer, taking a bunch of frozen blood samples out, thawing them, and measuring a bunch of things. One of them is to leverage what is available through our daily clinical practice using discarded clinical specimens. So Dan Roden is an electrophysiologist at Vanderbilt. He created about a decade ago a biobank at Vanderbilt known as BioView. And the way BioView got created is that every patient that walks into Vanderbilt University Medical Center, when they check in, gets presented on their little touchpad with this consent. And what it reads is, I agreed to donate my leftover blood specimens or tissue samples and share my de-identified health information with BioView and approved researchers, understanding that I'll receive no compensation for this donation, and that I will not receive the test results for anything that's done in the blood sample. This was originally done as an opt-out. In the last 5 or 6 years, it becomes an opt-in. So it requires you to consent to say, yes, I want to do this. And yet, despite the opt-in, still about 75% of patients that walk into Vanderbilt, into the medical center, agree to donate their unused blood specimens for research. And so there's a robot in the clinical pathology lab that, based on the answer to this consent form, will collect or not collect the sample when it comes through after it's been used. So if you send a blood sample down for chemistries, it gets processed. By the lab rules, it has to then sit there for a couple days to make sure that you're not adding on any tests. And then when it's done, the robot will grab it and put it into a freezer, extract the DNA, either toss out the plasma, or as we'll talk about, we start to keep the plasma. And it will be saved in perpetuity. And again, 75% of the patients who walk into the medical center, this is done for their plasma. It's de-identified, and so all the identifiers are stripped, and it's paired with the EHR record, which is also stripped of all identifiable information. And so this is BioView. BioView is composed currently of about 250,000 unique DNA specimens collected from these discarded samples. It's a subset of what we call the synthetic derivative, which is basically our research electronic medical records. So everyone who walks into the Vanderbilt Medical Center gets their clinical data stored in a de-identified manner. So 2.5 million subjects, because this goes back for multiple decades, have data in there. Since BioView is younger, it only has about 250,000, but it adds about 500 a week. About 2 years ago, there was an effort funded to start genotyping, doing deep genotype chip genotyping of a large segment of BioView. So currently, we're nearing 100,000 samples within BioView have been fully genotyped. Hopefully in the next year, we will exceed that. And this is all funded institutionally. One other thing I just wanted to point out is that although this is done primarily for research, a lot of this process can be leveraged for clinical use as well. And so this is from a pilot called the PREDICT program, where based on the genotyping information that's collected from patients when they come in, clinicians who prescribe medications that have known pharmacogenetic interactions like Plavix with the CYP2C19 variants, clinicians actually get to see a pop-up in their daily clinical activities that tell them that based on genotyping that their patient may be a slow or intermediate metabolizer of Plavix, and actually offers them alternatives like prasugrel or other non-Plavix platelet inhibitors if they're slow metabolizers of Plavix. And so in a small way, some of these data have started to get incorporated into clinical practice. So getting back to the biomarker question, when we arrived at Vanderbilt, we had the idea that at the time, throwing away all the plasma to collect the DNA probably wasn't that efficient, and maybe the plasma could be used for something. Now, it was actually a little bit uncertain that the plasma that was collected from BioView could be useful at all, because remember, as I mentioned, by rule, the sample had to sit in the lab for a couple days before you could use it, because you had to have the opportunity to add tests onto that. And there had never been in the epi cohorts any experience with dealing with plasma that basically sat on a counter for a couple days. And so we initially did a pilot study looking at a specific diagnosis, heart failure. So using this automated algorithm, we basically told the robot, if the person has heart failure in their medical record, collect that plasma specimen. And then we collected a bunch of controls as well. Over the course of 3 months, we collected over 1,300 cases and controls, and this was without any human interaction. So there was not a research coordinator, there was not a human that went to the bedside and consented the patient. This was all done in an automated manner, about 12 samples a day. We then took a small subset of these specimens and applied the SomaScan. This is work done with Quinn Wells and Deepak Gupta, who are 2 junior faculty members in our division. And these are some of the initial results. So we screened over 1,000 proteins in about 100 patients. And we got 9 proteins that distinguish cases of heart failure from controls. Some of them are pretty obvious, like cystatin C, a measure of renal function, renin. There are a bunch of other markers that are relatively novel for heart failure. We then attempted to validate these findings in a completely separate cohort. So this is the Stratify study. This is a traditionally collected heart failure study. 2 of my emergency medicine colleagues, Alan Storrow and Sean Collins, conducted the study at Vanderbilt in people with shortness of breath. Subsequently, about half of them were diagnosed with heart failure, half of them diagnosed with another cause of their shortness of breath. We did ELISAs on the 9 biomarkers on the last slide, and 2 of the biomarkers validated using ELISA, thrombospondin 2 and angiopoietin 2. And this is in the validation cohort, how these biomarkers perform. So if you look at the area under the curve for physical exam findings in someone with shortness of breath for identifying heart failure, you get an area under the curve of about 0.6. These individual biomarkers, BNP, angiopoietin 2, thrombospondin 2, do about the same. So individually, they do about the same as physical exam findings. However, when you put them all together, you actually can increase your area under the curve from what you get from the clinical score alone from about 0.7 to 0.78. And so it does augment the information that you get just from the clinical assessment of the patient with shortness of breath, just from adding these biomarkers that we discovered from this screen, just from a relatively small pilot study. Interestingly, we then went to this epidemiologic cohort in Sweden that we collaborate with and found that these same 2 biomarkers, if you measured them in the Swedish cohort, predicted future heart failure. So if you take a bunch of people without heart failure who are relatively healthy and follow them, and these are frozen samples, so we had follow-up over 20 years, we actually can predict a little bit who develops heart failure from this group using these 2 new biomarkers. The other thing that we have done is something that I've done with Dan Roden's group. And so this is Jonathan Mosley from his group who's collaborated with us. And it's basically taking the concept of how about if you actually tried to conduct these proteomic studies without measuring the blood samples at all? So can you do it virtually, just using what you have in the data set? And so this is the concept. We have traditional cohorts like Framingham where we have a couple thousand people, where we have plasma, we've done a lot of proteomic studies, metabolomic studies, and then we have very large cohorts like BioView at Vanderbilt or the UK Biobank in England that have hundreds of thousands of samples. However, in these very large biobanks, there is almost no plasma collected. However, both of the sets of cohorts, the epidemiologic cohorts, as well as the very large cohorts, have DNA collected, because these were cohorts that were started to collect DNA. And so the concept is to take the DNA and to create in the small cohort a genetic predictor for every single plasma protein that you measure. So in Framingham, where we've measured about 1,100 proteins, we use the genotype information and create a genetic predictor for levels of each protein in each individual. And then we impute that. We basically go backwards and in the very large cohort, take the genotype data and create a predicted value of the protein. Hasn't been measured, so it's a virtual protein. It's just a predictive value based on the genetic data. The advantage is in the very large cohort, not only do you have more power, you also have thousands of clinical diagnoses because you're taking it out of an electronic medical record. So you can take 1,000 proteins and relate it to 1,000 diagnoses in a single large virtual experiment. And so Jonathan and our group have worked on this for the last year. This is just proof of concept stuff, but in BioView and then Emerge, another cohort, in 42,000 people or so, we have looked at this virtual experiment, and you get several hundred associations between proteins and diagnoses. And so if you just hone in, for instance, on results for vascular disease, we get 7 findings. So these are the virtual measured protein, the clinical diagnosis in the EHR, and this is the pattern. So some are associated with higher levels of the clinical diagnosis, some are associated with lower risk of the clinical diagnosis. And then we validated this using the directly measured protein in the epidemiologic cohort and MDCS. And the patterns are very similar. It's not perfect, but the proof of concept we feel exists that doing these virtual experiments, we may at least be able to identify low-hanging fruit of protein disease associations that might be informative for our future validation work. Just to finish up then, this prediction part of the talk, and moving very upstream, there's actually been a lot of attention now on purely using the genetic data, on genomics, to predict who's going to develop heart disease, these polygenic risk scores. And the concept is based on the GWAS studies of coronary heart disease that have been done for 5 or 6 years now. We now know across the genome that there are many genetic variants, many common SNPs that are associated with the risk of coronary disease. The most well-studied one is the one at 9p21. We still don't actually know what gene it comes from, but there are a group of SNPs at that chromosome that has a very high statistical association with coronary heart disease. But there are all these other things that have now well-validated associations with coronary heart disease. So the concept is taking all these data from the genetic variants, and since genotyping is relatively inexpensive now, in any individual person, genotyping variants across your genome, millions of genetic variants, and seeing how well those predict coronary heart disease. And so a number of groups, including Seth Catharacen's group, former colleague at Mass General, have done these. And these are called polygenic risk scores. These are risk scores composed of genetic variants from a genotype chip. This particular one includes over 6 million common genetic variants. And what Seth's group found is that people in the very highest decile of polygenic risk score, people who have polygenic risk, who have genetic variants that put them at the highest end of that risk distribution, have about 4-fold risk of developing coronary heart disease, which on the face of it is a relatively exciting result. The question is, how well do these polygenic risk scores add to the clinical data that we already have? And we're now getting the data on that. So this is, again, based on the Vanderbilt data. This is from the BioView data set, looking at the clinical risk factors based on the ACC-AHA pooled cohort equation, which in the Framingham EHR gives you an area under the curve for predicting future coronary disease of just under 0.7. These middle bars show that you can increase the area under the curve a little using the same clinical data, but mixing them up differently using machine learning techniques in an unbiased way to sort of look at whether you can develop better predictors using the same clinical data. And this purple box is what you get using the genetic data from BioView. So you can see it's a little bit better than the clinical predictors, but really not much. You're really not getting much more than you were getting way back 10 or 15 years ago just by measuring HSCRP in the EPI cohorts. This is another data set from Europe looking at the same question under almost 500,000 individuals, looking at the genomic risk score and conventional risk factors, and I just focus your attention on this box. So the polygenic risk score gives you an area under the curve of about 0.6. Conventional risk factors alone gets you an area under the curve closer to 0.7. So just traditional risk factors do much better than the polygenic risk score. This last thing shows you what happens if you add the polygenic risk score to conventional risk factors. And you do get an increment, just like you did with biomarkers, but it's not dramatic. It goes from about 0.68 to 0.7. And so the message should be pretty clear now that basically no matter what we have now, using all these various technology and variants, we're getting about the same bang for our buck. We're getting modest increments in our predictive ability. So I just want to finish the talk in the last 5 or 10 minutes then to sort of bring us back to the clinical scenario, because that's obviously why many of us have started this work. How does this apply to the clinic? How do some of the molecular technologies that are being explored for precision medicine translate into how we might manage patients without heart disease but at risk of heart disease? And I would propose there are really 2 ways we can use this information if we develop the information to a point where it's clinically useful. One is to use the biomarkers to identify specific targets for therapy. This is really, truly precision medicine. If we had a biomarker that told us what to treat and how to treat it. The second is a broader but potentially more accessible goal initially, which is to just use the biomarkers to identify people at higher risk. So it doesn't identify which therapy to use, but it just identifies a group of people that is going to be more likely to develop disease than their control group. And so while it doesn't tell us which therapy to use, it might allow us to more adequately target our therapies toward the right group of people. And so as an example of the first, I would say we already do it. And so With familial hyperlipidemia, which is a diagnosis based on a genotype or a mutation plus clinical data, we have very targeted therapies. We initially use a statin. This is just from the guidelines. We initially use a statin, but then we move into other more advanced and aggressive therapies for LDL, ending up at apheresis and some of the new RNA silencers, and then finally with PCSK9 inhibitors. And this is from a retrospective study showing that people with familial hyperlipidemia who receive statins do a lot better in terms of event-free survival compared to people without statin treatment. Interestingly, in FH, there has been no real randomized study looking at any of these therapies, partly because of the feeling that this is such settled science that it would be unethical to randomize people with FH to any type of placebo or control therapy. So this is an example of what I would consider truly precision medicine. We measure an LDL. In many instances, we get a genotype or a mutation. We diagnose someone or a family with an FH, and we become very aggressive about how we treat that LDL. A more recent example, at least a proposed algorithm, would be with HSCRP. And so I started a lot of the data examples with Paul Ritker. Dr. Ritker has obviously spent his entire career focusing on how one might use information about systemic inflammation to target people for therapies. And he's shown in a secondary prevention cohort in a trial, CANTOS, that people with high CRP levels who get treated with this monoclonal antibody against an inflammatory pathway have a reduced rate of recurrent events. It's not a dramatic reduction in rates, which is part of the controversy of this medication, but at least it's proof of principle that some people in whom you target inflammation will have a reduced risk of cardiovascular disease. And so again, this would be, in my mind, an example of using a biomarker and then choosing a targeted therapy based on that biomarker. Unfortunately, there are not a lot of other examples of this that I can think of, at least for coronary heart disease. And so then I'll shift to the second category, which is using the biomarkers, not so much to choose which therapy to use, but just to choose what type of people to treat. And this is an example of the high-risk strategy prevention. If you look at a distribution of people's cardiovascular risks along a continuum, the idea here is to choose people at the upper end of this distribution, because these are the people most likely to get cardiovascular disease, in whom the risks and benefits of treating preemptively are going to be more favorable. And so as an example of the high-risk approach that is now being proposed, if you've been paying attention to the press that's come out after the polygenic risk score data, a lot of people have now been thinking that maybe on the basis of this polygenic risk score information, you can identify people at the top end of the risk distribution genetically and target them for more aggressive therapy. And so this is, again, from, say, Katharason's group, looking at the people in the top 2.5 percentile of polygenic risk score. What have you targeted these people? There's a problem with this strategy, though, and it was partly prefaced by my comments earlier about the polygenic risk score. If you choose this approach, suppose you say, let's say people in the top 2.5 percentile of the distribution, who we know have a much higher relative risk of developing coronary heart events, you unfortunately identify fewer than 10% of the events that are going to occur. In other words, remember the prevention paradox. Most of the events that occur in the rest of the distribution, not in that upper tail of the distribution. The problem is even more challenging, because even the people who you identify in that top tail of the distribution, 9 in 10 of those people are not going to get events, at least in the foreseeable future. We know that from the epidemiologic data. So even though they are, quote, high risk, this is not deterministic. They're just relatively higher risk than the rest of the population, but you're still treating a lot of people who are likely not going to get events over the next 10, 20, maybe 30 years. And lastly, as I mentioned, the performance characteristics of this predictor are about the same as HSCRP. And so at least in 2019, it's not clear that you would need to genotype 6 million SNPs to get the information that you want. If you really wanted to target a tail, you might as well measure a CRP or a BNP, a single protein biomarker. And so is there an alternative to this? Are we sort of stuck in place? And this goes back to a very old idea in epidemiology, which is the high-risk strategy is one approach, but there's another approach, which is the population strategy. So instead of targeting the people at the very upper end of the distribution, what if you were able to shift the whole distribution of risk? You're not shifting it a lot, you're just shifting it a little bit, but you're shifting it across the spectrum. And so based on the sort of nomogram that I showed earlier, you might recognize this is a thing that we've been trying to get rid of this whole time, which is the one-size-fits-all medicine, basically treating a whole population in a uniform way. And so the idea here is that we know from our data, and this has been shown over and over again, that population-based strategies will in general prevent way more events than any type of targeted strategy. However, it's obviously only applicable if you have a low-cost intervention with few side effects. Otherwise, there's no way you treat the entire population or a broad swath of the population. And so there are population strategies. One is diet and exercise. If you pay attention to any of the prevention guidelines, we basically say that everyone should eat a good diet and exercise. The problem with that is these lifestyle modifications are incredibly hard to implement, as you all know. There are actually other examples of population strategies. Outside of cardiovascular disease, we use vaccines. We give vaccines like the flu vaccine across the population, regardless of what their specific clinical characteristics are. Another thing that a lot of people use are vitamins. Vitamins are low-cost pills. They have virtually no side effects. The problem with most vitamins is they virtually have no basis in evidence, whether you're talking about preventing osteoporosis, chronic disease, or other things. And so what if you had a vitamin to prevent cardiovascular disease, a low-cost pill with few side effects, but that actually had data for preventing cardiovascular disease? And so, in fact, that concept has been proposed and it's been around, and some of you may have heard. Over a decade ago, a couple folks in the UK, Walden Law, proposed that if you gave the entire population of people over age 55 a simple pill containing an aspirin, a statin, and a couple other medications, you could prevent most cardiovascular events. Very controversial proposal for obvious reasons. What is a polypill? As I mentioned, it's a combination pill. It has to contain low doses of these medications because you don't want to expose people to side effects. It also has to use fixed doses because the simplicity of the pill, other than it being once a day, is that you're not tinkering with it. You don't have to bring people back every couple months to check blood tests or check their blood pressure. It has to obviously be low cost because you're giving it to a lot of people and you're giving it once a day. And so you might ask, well, doesn't this go against everything we know about how we target cardiovascular disease? Shouldn't we, for instance, use baseline LDL to target statin therapy? And so I'll just summarize quickly because I think you're all familiar with the data. There are no evidence that the benefit of the statins for reducing relative risk of cardiovascular disease has anything to do with either baseline LDL cholesterol or, for that matter, overall cardiovascular risk. Similarly with blood pressure, although we have thresholds for blood pressure, and those have been recently reinforced in the guidelines, most of the data suggests that down to a blood pressure of about 120 over 80, we have sustained benefit from lowering blood pressure. We also know that the side effects from blood pressure medications are dose-dependent for almost all classes of blood pressure medications. And so if you want to reduce the blood pressure a certain amount with the fewest side effects, it's actually better to give multiple medications with different mechanisms at low doses rather than our traditional approach of titrating one medication at a time to its highest dose. And so then you'll ask, what about the guidelines that tell us all the things that we should do to target these therapies? So I would suppose if you just look at that slide, a bunch of highly trained cardiologists and look at our current guidelines, they are extremely complex. Consider the challenge for a primary care doctor who's taking care of multiple chronic diseases, who has to look at these guidelines and decide what to do with a patient sitting in their office. And so I would argue that this is one of the reasons why our conventional approaches to prevention aren't all that effective. We know from the data that less than half of patients stay on their assigned cardiovascular medications for greater than a year. And more than half of individuals with hypertension actually have their blood pressure controlled. And I would also argue that in particular populations, including low-income populations, this is an incredibly tall challenge. I live in an area of the country in the southeast that has very high rates of cardiovascular disease. The fact that there's such regional disparity in rates of cardiovascular disease emphasizes the practicality of some of these barriers. And this is just the last couple slides. We have embarked in the last couple years on an effort in our area to study this, the use of the polypill in primary prevention in a low-income, underserved population. This is done in collaboration with Bill Blott, who's a cancer epidemiologist, Dan Munoz, who's one of the junior faculty members in cardiology. This was funded by the American Heart Association about 4 years ago. We've randomized over 300 individuals in Mobile, Alabama, to receive a Polypill or usual care, and we're following the risk factors. This population is relatively underserved, over 70% African American. 3/4 of the study population have an annual income of $15,000 or less. About 2/3 are at the poverty line. And this is the Polypill. So this is an AHA-funded study, so not a lot of money. So we basically took this capsule and we put these 4 low-dose medications into the capsule. It's a daily medication. The study's actually already completed follow-up. I won't be sharing data at this talk, but I can tell you it was well tolerated with a very high rate of compliance with this pill. And those data, hopefully you will be seeing very shortly. So I just wanted to wrap up, going back to sort of where I started with precision medicine, which, as Bill said, I chair this council on precision medicine. I believe in it. I think these technologies have the potential to really advance healthcare. But in terms of how to apply it to prevention, I think we have to be thoughtful and recognize that precision approaches are not going to be broadly applicable to all the things we try to address in prevention. And I think that it's not an either or. Cardiovascular prevention will not rely on either population-based approaches or high-risk approaches. It'll depend on the therapy and the patient population. And so I think for some patients, the high-risk strategy makes a lot of sense. Those strategies are obviously appropriate if we have therapies that are costly and toxic, like PCSK9 inhibitors. You would not be wanting to give those broadly. And so for those therapies, we want to target them. And we want to target them using the biomarkers that I've talked about, which may advance prediction only incrementally, but that increment still is going to be helpful to spare broad numbers of people these toxic therapies or risky therapies. On the other hand, I think we need to be more open-minded about using broad population-based or at least hybrid approaches for therapies that are relatively low cost with few side effects. So this is my last slide. Just wanted to acknowledge my many collaborators back in Boston, now at Vanderbilt, who've worked with me over these years on some of the projects that I've talked about. And I thank you again, thank Dr. Zoghbi and his colleagues for having me today. Thanks very much.
Thank you, Tommy, for a wonderful presentation, really going through from the basic sciences to the clinical and clinical implications. Questions for Dr. Wang?
Good morning. Outstanding talk, and I really enjoyed it. A couple of questions. The first one, has any of these scores, whether biomarker or polygenic, been associated with early phenotypes of coronary disease, whether calcium score, or like cardiometabolic fitness, or like myocardial blood flow? The other question are, what are the implications of identifying someone who's clinically healthy, fit, but having this being in the highest tertile for a polygenic risk score on other activities, whether like lifetime insurance, resource utilization? We're identifying someone as high risk for developing coronary disease, but he's living healthy life and he doesn't have anything. What are the potential societal implications and for the patient?
Those are great questions. So on the first question, yes, and I haven't talked a lot about the non-soluble predictors, but it turns out the biomarkers and the conventional risk factors are all highly correlated with many intermediate measures like coronary calcium and vascular function. And in fact, coronary calcium itself is a relatively simple measure, has been also proposed as a way you might predict risk. And it turns out, if I had to choose a single test to predict future disease, coronary calcium is probably the best test. The issue there is just it's slightly higher cost. It's coming down. You can get a coronary calcium scan where we are for less than $100. But there's the radiation too, and I think that's a little more of a consideration, although it may only be a couple millisieverts. If you're talking about doing that on a broad scale, it's still not entirely certain the risk-benefit of them. That all being said, I think coronary calcium, perhaps in some of these other measures, do have promise for adding to risk prediction, and because they're looking at established disease, may be better than a lot of the soluble biomarkers. But the soluble biomarkers are much more practical for clinical use. The second part of the question is a tricky one, obviously, and applies to not just cardiovascular disease, but cancer and other things. What happens if you look like you're at high genetic risk for a chronic disease? Is that going to impact your insurance and other things? As you probably know, there are laws in place like GINA that have tried to prevent that from happening, and it's going to be an important policy question to prevent the genetic information from adversely impacting your finances and costs going down, because genes are not fate. With the exception of Mendelian mutations, and even for some Mendelian mutations, what's in your genetic background does not actually determine whether or not you're going to get the disease. And that's especially true of the polygenic risk scores. The distance between the polygenic risk score and the disease is an enormous gap, to your point. And on top of that, and the point that you're making is that, and we have data now, SAKE's group and other groups have shown that even if you are at high genetic risk, you can still lower that with a good lifestyle. And so it's a combination, it's very multifactorial, which is why I think it's dangerous to think of the genetic risk score, and part of my comments are based on the fact that the lay press has really gotten excited about this. But it's dangerous to think of the genetic risk score as deterministic, because it really isn't. It really is just another tool, like measuring HSCRP, that incrementally gives you a little more information on whether someone is at high risk or not, but does not at all say what's actually going to happen.
At least for this disease, I mean, that's the difficulty.
Yes, for our disease, yeah, and that's why cancer is cancer in precision medicine is much different, because you have tissue. Many of these are mutations in that tissue. To equate that to cardiovascular disease, it's a much different situation.
Barry. Thank you for a great talk. I really enjoyed the dynamic nature of all the work you've done in this field. It's incredible. My question relates to the phenotyping part of it, and how you tie that into the genomics and the proteomics and metabolomics. So in terms of for different disease processes, for example, I'm interested in genomics of patients that are get chemotherapy, cardiotoxicity. How would you advise? I mean, if you can get a very large population from databases that don't have as much phenotypic data versus a smaller population without that larger sample size, but has a very carefully described phenotypic cohort in terms of the granular details of the patient, risk factors, et cetera. Just in terms of kind of a broad question in terms of how you would advise people in this field to...
Yeah, that's a great, so is the age-old question in clinical observation research, which is large population, low-resolution phenotype versus small population, high-resolution phenotype. Our group has done both, and I've come to the conclusion that you probably need both. For discovery, I think large populations are useful, because it's hard to do any of these platforms when you have small populations, because the burden of the statistical multiple testing penalty is so large. And so if you're measuring 1,000 proteins, if you have fewer than 1,000 people, you're already at a disadvantage. So our general approach has been to do discovery in very large populations, but then to validate or to do follow-up in small populations. And I would say that the small populations are a combination of populations, small groups of people where you have very dense phenotyping data, as well as perturbations. The one thing that I've come to appreciate the value of are populations of individuals or patients who are undergoing an intervention, like in cardio-oncology, if you get them pre and post their chemo. Or what we do for a lot of preclinical heart failure stuff, we do a lot of salt loading and things like that. And so in those very small populations, you can get really good signal, but you still can't really do discovery in those populations. Discovery is really, for a lot of these things, easiest to do in the large data sets.
And just to follow up, does that differ whether it's genomics versus genotyping versus proteomics?
Yeah, my feeling is that all these molecular technologies are similar. And so the way genomics used to be done is we used to do these small studies and do candidate genotyping, and we found out after a while that all the stuff that we were finding was probably a false positive. So it was only until we got to the really large populations that we started getting these robust findings. I think proteomics metabolomics is going through the same problem, that everyone started with the small studies, but we're now realizing that you really need large studies to have confidence in what you're finding.
All right. Yeah, fascinating work, and it's a lot of work in trying. I think I'm really impressed with the biobank that you were able to systematize this, and thank you for being here. I see part of you as a preventive cardiologist, part of you as a biologist. My question to you is the practicality and impact of all that we're doing. And what I'm trying to ask is the genomics and the risk prediction, especially the genomics, gets very overwhelming soon. I'm dealing with small mice and genomics, and then I'm already lost, and you're looking at a 250,000 sample. While we're spending time on trying to figure this out, you've shown for a decade we came up with 10 risk factors that haven't panned out. Are we wasting time while we can go and fix a simple biomarker, which is blood pressure? And the viability of fixing blood pressure has not been panned out in the country because there's no money in it. So my question is, after all this effort, will there be a financial viability of a technology like this to be implemented at a population base that, I mean, end of the day, the reality is if there's no financial gain, I don't see things getting implemented as much. So this is a challenge to effectiveness.
It's a fair question, and it's actually one of the reasons after I moved, one of the things you learn about moving is that it allows you to do different things and reset some of your expectations. It's one of the reasons after I moved that we started getting into this Polypill stuff, which is the recognition, to your point, that there's a lot that we already know. We know that lowering blood pressure and LDL cholesterol works, but we're not doing it. And so, to your point, restating, we can get all this fancy information, but we're not even doing the stuff that we already know works. And so that's how we got into the Polypill. When I started realizing there are all these populations in our country that aren't getting the right therapies. Are there better ways of delivering these therapies? But we haven't given up on the other stuff, partly because I think that there's a lot, even if we don't quickly achieve the goal of precisely identifying people who are going to get disease, there's still a lot you learn about biology. And so a lot of these modest effects that we're finding, while they may not have dramatic clinical effects for identification, they could translate into drug targets. You know, HMG-CoA genetic variants predict cardiovascular disease. They're very weak variants, but they predict cardiovascular disease. If we had not had statins, though, that would have clued us in that that might be a pathway to target. So the biology is still very important. So I think there are multiple reasons for doing the biomarker stuff in the genetic discovery, even if, to your point, there are other things that I believe as clinical investigators we also need to be pursuing to ensure that we can deliver therapies to the clinic more in the short term.
Very good.
Bill, one more question, if you don't mind.
Quickly.
I loved the title and the introduction of precision medicine, but I'm more fascinated by the fact that you're entering a program of the most imprecise medicine for low-dose pills in a capsule that you're giving to everybody in the community. So you might have to change the title to imprecise medicine.
That's right. That's right. Yeah. No, it's true. It's a bit heretical. But I guess what we like to say is that it's not mutually exclusive, and it's like taking vitamins, right? So if you're a vitamin taker, there are people who take multivitamins every day, but there are people who, on top of the multivitamin, might take vitamin D supplements if they're vitamin D deficient, or hormone therapy. In other words, you could be taking both the imprecise therapy, but you always can take the precise therapy on top of that. But it is heretical. I think investigators have to be in equipoise, and I think that you still need to sort of enter this with an open mind.
All right. Well, Tommy, thank you for an amazing presentation and great discussion, actually, on precision medicine and maybe a broader, less precise medicine, but still the goal is try to get there. Thank you very much for your attention.
Thanks a lot, Bill.
Oh, that was great. I loved it. Just love the challenges that you go.
Yeah. Thanks again. Yeah.